Hi, I'm Dr. Lewis Hassel and professor of pathology at the University of Oklahoma. Welcome to our program, Digital Slide Review and Sign Out. Our case today comes from the realm of surgical pathology of the GI tract and is, in my experience, rather unique, although apparently this is a fairly common finding in a number of other settings. So the patient is a 50-year-old man, 58-year-old man who presents for his first screening colonoscopy. And of course, we see those virtually every day, and the hunt is usually on for polyps, precursors of gastrointestinal malignancies. So it starts out as a routine case and ends up a little bit unusual. From the endoscopist's point of view, it was fairly routine. There were multiple polyps, which they successfully resected. You can see several of them here marked. Some of them are up to 15 or 16 millimeters in size, but otherwise not too particularly remarkable in this gentleman who had been followed and referred by his family physician for colonoscopy. The endoscopist did not see anything that looked particularly remarkable in this, did not describe any unusual vascularity. Aside, you can see some of the hemorrhage there as the lesions were resected. Of course, you're going to realize here quickly that these were not typical pre-malignant polyps, tubular adenomas, or serrated adenomas, or so forth. So what are the sorts of things that can clinically mimic an enteric polyp? Well, not infrequently, we see situations where the lymphoid aggregates may be particularly prominent, the mucosa somewhat thinned, and these little bumps, several millimeters in size, may jump out, particularly if they aggregate together. We also note that our surgeons or our endoscopists can frequently detect little areas where the mucin coming out of the colonic crypts is particularly prominent, and they will often biopsy these, sometimes showing dilated glands, which may be incipient polyps. Similar changes sometimes are seen adjacent to more dysplastic polyps and so forth. Then, of course, there's a number of submucosal lesions, primary of which are the lipomas, leiomyomas. And then less frequently, inverted diverticuli that sort of bulge into the lumen rather than evert out of the lumen. Fecal debris occasionally will deceive the naive or the inexperienced. And then occasionally inflammatory lesions, pseudopolyps and so forth, can also present in this manner as mimicking a true polyp. So let's look at the material which we received on this patient. These were the right-sided polyps, which were resected, as we indicated, several millimeters in size. And as you can see here at very low magnification, there's not much of an indication of dysplasia. Rather, what we're seeing are both fairly good-sized aggregates, but also some interspersed inflammatory changes resulting in a bit of mucosal hyperplasia, elevation of the mucosa with this intervening infiltrate, which is composed of a mixture of inflammatory cells, some plasma cells, lymphocytes, and has in a few foci some degree of crypt damage, as you can see there. We'll look around a little bit more at some of the other areas of this sample, just to see it a little bit more fully. Here again, we see increased blue cells between the glands, giving this pseudopolyp in appearance. Not much in the way of crypt destruction here, maybe a little bit of variability in the size of those. And then a little bit more over here, I think you can see there's These glands come down to the muscularis mucosa, but there may be a little bit of branching to some of these glands as well. But in general, the finding is a somewhat diffuse, regional, sort of localized diffuse enhancement of the lamina propria inflammatory cells. These prove to be a mixture of T and B cells, as well as polyclonal plasma cells as well. The second sample, which was more from the left side of the colon, had fairly similar findings. But as you can see here, there's a little bit more destruction. Here's a crypt that's quite nicely ruptured and so forth here. Additionally, as we looked around a little bit further, we saw more of that variability. And let's see if we can find it here. There were also, yes, here you can see them coming into focus here. Areas that looked maybe like they may be dysplastic, but I think really were the inflammatory changes, because as you look here, in fact, you can see very nicely that we have this crypt abscess here, here, another one over here, with just abundant neutrophils in the lumen of this crypt, loss of part of the mucosa there, but otherwise no specific, no granulomas and so forth in this particular area here. And this type of inflammation also involved this tissue here, which sort of has the pseudo tubular adenoma type look to it, with a lot of active inflammation here within the epithelium as well. So inflammatory lesions, focal crypt abscesses, expansion of the lamina propria, mixture of T and B cells, sort of patchy sort of changes. What are we to make of this? Well, at this stage, I thought it was important to go back and review the patient's history a little bit more fully. As I did so, I discovered that he'd had fairly long-standing bilateral hip pain and carried in his problem list a history of ankylosing spondylitis. And that piqued my interest, and I did a little further evaluation. I don't usually see patients with spondyloarthropathies and so forth, but I thought it might be interesting, knowing the inflammatory nature of that disorder, to consider whether or not this might be a problem related to his arthropathy. So we've talked about things that mimic colon polyps. Let's talk a little bit about ankylosing spondylitis. This is a fairly common spondyloarthropathy, which has a very significant autoimmune component and a particular association with HLA types B27. But in addition to involving the skeletal and sacroiliac joints particularly, it can also have significant extra-articular manifestations, most notably a uveitis and inflammatory bowel lesions. Now, it occurs in both Eastern and Western populations. I've seen several studies from Asian populations and so forth, as well as in the Caucasian, Northern European populations, but where HLA-B27 seems to be more prevalent. But in each of these locations, there is an identified inflammatory bowel component to this disorder. It's uncertain what the exact mechanism of interaction there is, but it's believed that bowel flora may be involved in the triggering event in ankylosing spondylitis, much as we have come to hypothesize for other inflammatory bowel lesions, such as Crohn's disease and to a lesser extent, ulcerative colitis. Now, the involvement of the bowel in ankylosing spondylitis can often be subclinical. And so patients may be just treating their, joint symptoms without any recognition of diarrhea, abdominal pain, blood loss, et cetera, et cetera. And in fact, even when examined microscopically, these can often mimic Crohn's disease most commonly, but occasionally even ulcerative colitis and other inflammatory lesions as well. The most acute lesions have an abundance of PMNs with some lymphs and plasma cells in the lamina propria, not unlike what we saw, but more chronic lesions will usually result in architectural distortion, occasional granulomatous, fused crypts, and so forth, and more dense, deep lymphoid follicles. I think in our case, the patient's had this disorder for some time and probably has something in between an acute lesion where the crypt, the lamina propria neutrophils would be more prominent, and the chronic lesions where the evidence of crypt damage and destruction and architectural reorganization would be expected to be more complete. So given that presentation, given that history, we made the diagnosis on this patient of ankylosing spondylitis-related colonic lymphoid inflammatory infiltrate forming pseudopolyps and referred that back to the patient. There was not unequivocal evidence of tubular adenoma or other things in this case, so we did not deem him at risk for other disorders in that regard. Well, thank you so much for joining us with this, and I hope that you found that discussion a little bit enlightening. Certainly, it was a learning experience for me to cope with this case, so I try to share that with you a little bit. And if you like that, please hit that like button. That helps more people to find our videos. And of course, we welcome you and encourage you to subscribe so that you'll catch future releases from our channel. So until next time, thanks so much for joining me.